I won't narrate your list of accomplishments, but just like tell everyone in the audience like who you are. So Dr. Lercher is an assistant professor specializing in rehabilitation and physical medicine with affiliations in Mount Sinai Morningside, Mount Sinai West, Mount Sinai Beth Israel, and Mount Sinai Hospital. So his work has primarily focused on those domains, and today he's going to speak about chronic traumatic encephalopathy. And feel free to share anything that I missed.
All right, thank you, Sharik, and thank you everybody for joining today. And it's a pleasure to be here and presenting as part of the Columbia Synapse conference. Like Sharik said, my name is Kirk Lercher. I'm the medical director of brain injury medicine at the Department of Rehabilitation and Human Performance at Mount Sinai Hospital. I'm also the fellowship program director of our brain injury medicine fellowship. And it's an honor to present today on this topic of chronic traumatic encephalopathy. So let's see if I can use this. Perfect. Again, we're still seeing the right slide, right?
Yeah.
Okay. So this is an outline of how I'm going to present this discussion. So first, I'm going to define what is chronic traumatic encephalopathy, give a little historical perspective, and how we got to understand the pathology, talk about epidemiology, review some risk factors, pathophysiology, and some classic neuropathologic findings. Then I'll go over some clinical presentation of that's typical for CTE, and then also review some prolific cases. And then we'll talk a little bit about future directions in terms of research and what's on the horizon. So first, definition. Various groups have kind of come together to try to come up with a concise definition of what CTE or chronic traumatic encephalopathy is. This is 3 examples of major groups that published on it and kind of came up with this definition. All of them kind of have a similar theme, which is that it's a progressive neurodegenerative disease that follows repetitive head trauma, usually in an athlete that's characterized by a neuropsychiatric worsening in their condition, and on pathologic findings has a very characteristic finding associated with hyperphosphorylated tau protein and neurofibrillary tangles, which we'll talk about what that means. But that's the general gist. So a neurodegenerative condition that follows repetitive head trauma with very specific neuropathologic findings. So historical perspective, it was first described in 1928 by Dr. Harrison Martland. He was a New Jersey medical examiner, and their kind of neurocognitive abnormalities. Later, this term was replaced in 1937 by Dr. Millsbaugh and was called dementia pugilistica. Dementia pugilistica was meant to kind of maintain the relationship to boxing, pugilistica kind of meaning combatants, and dementia kind of giving an overarching theme of their neurocognitive decline. And then this picture here is just as Dr. Martland, and then I threw in there for context over in Newark, New Jersey at the University Hospital there, they have a building that was the original hospital from ages ago that's still named after him, the Martland building. So a little more history. So as the evolution of other sports like American football, soccer, ice hockey, professional wrestling developed, we started seeing similar symptoms as what Dr. Martland described, but now in athletes of other sports. So in the 60s, it was renamed to what it's known as now, which is chronic traumatic encephalopathy, or CTE for short. Now, CTE became a popular topic due to its relationship with professional athletes. Many retired athletes struggle with depression, substance abuse, anger, memory, motor disturbances, and in some tragic cases, even committed suicide. And autopsy results suggest that there's this association between these emotional, cognitive, and physical manifestations and these findings of CTE. Interest in CTE also stems from the United States military, in that many servicemen and women returning from deployment are exposed to significant amount of blast exposure as well as closed head injuries. The military estimates that somewhere around 300,000 military personnel are affected by this. And Bennett Amalu, who is published the first cases of retired NFL players to be found to have this, published a case about 10 years ago on a U.S. Marine Corps veteran who was in the Iraqi war and returned with a history of significant blast exposure and was found to have a progressive cognitive and mood impairments. He ultimately committed suicide, and his family donated his brain, and he was found to have these findings of CTE. So the military, this is a very of strong interest in the military because obviously the way wars are fought now, there's a lot more potential blast exposure and the closed head injuries from like rollover accidents and stuff like that that the military will be exposed to in the future. And so this also gained popularity in the lay media as well. So especially as in its association with professional sports, a lot of news serial programming was released to the public, and many episodes of scripted television programs have had storylines that involved, um, the development of this condition of CTE. And a few years back, there was even a movie on Bennett Amalu where Dr. Will Smith played Dr. Amalu and told his story of how he found CTE in retired NFL players. So the epidemiology. So concussion or mild traumatic brain injury is one of the most common neurologic disorders. It accounts for about 90% of all brain injuries that are sustained. And the annual incidence occurs between 1.6 to 3.8 million, depending on which source you look at, of sports related concussion. And likely this is still a gross underestimation. In the years since we've grown to have a better understanding of the effects of brain injury and how to screen for it, there's been an increased ability to bring patients in, but we're likely still missing a lot of athletes that may have sustained an injury, but then still either go back to play, or maybe they didn't really have symptoms, so they didn't present to the doctors or report it. So we believe that this is still like an underestimation, though it's a far greater number than we had previously. And the CDC report that sports-related TBI, including concussion among children and adolescents, increased by 60% in the first decade of this millennia, with sports such as football, basketball, bicycling, and soccer being the primary sports involved in that report. The exact incidence of CTE, however, is largely unknown. Most of what we do know about CTE comes from these case reports and case series from two large independent research groups. One is known as the Brain Injury Research Institute in West Virginia. That's led by Dr. Amalu, who again reported the first two cases of CTE in retired NFL players. And then the Center for Study of Traumatic Encephalopathy, or CTSE, out of Boston, is led by Anne McKee and her group. And their claim to notoriety is that they own the largest repository of brains that exhibit findings of CTE. Now, Anne McKee's group published on a cluster of these autopsy brains that they had, and they found that out of 51 neuropathologically confirmed cases of CTE, 90% of them were in athletes. And they reported that, again, American football, boxing, soccer, ice hockey tended to be the sports that these athletes participated in. And many of those that they examined began playing as young as 11 or in their adolescence, 11 and 19 years old. And it is unclear at what age these CTE findings can actually begin. But they have been found in athletes as young as 18 years old. So what are the risk factors? So risk factors, there's a group that put together a list of these common risk factors so that people are aware of what may predispose one to developing this. So first of all, head trauma. There's debate about whether a single or repetitive injury is needed to kind of predispose one to getting this, but that is a risk factor. A history of a concussion, which is a milder form of head trauma, but still a documented series of symptoms that follow a head injury, is a concussion. So having a history of that documented is a risk factor. And then participation in any of the following activities. So boxing, obviously, American football. I use that image to kind of highlight that our understanding really of how American football contributes most to this is not so much from big, large impact concussions, but more from line of scrimmage, headbuttings of people, charging at each other every single play and having that chronic and repetitive mild head injury. Soccer, professional wrestling, hockey. I use this image to really highlight it's body checking that is considered the most dangerous or most likely to induce a traumatic brain injury, where one player is charging full speed on ice skates into a hard wall to have sudden stoppage in their momentum of movement, causing really significant jarring forces to the brain, which can result in symptoms of TBI, even if a direct head impact is not sustained. And then finally, military service, in particular, as I mentioned, blast injury. And then the length of participation in any of these activities is also a risk factor. If you're more exposed to a longer period of time over a career, you have an increased risk. Other risk factors include epileptics or people with seizure disorders, particularly if their manifestation of seizures results in a lot of head banging type of activities, victims of domestic abuse, patients aged tends to be a risk factor as well, with patients at the very young age range and older ages tending to be at increased risk as well. And we'll go into that in a little more detail. And then there's genetic variations. So I'll talk about this in a few slides down, but ApoE3 or ApoE4 have been shown to be variants that people have that might predispose them to developing CTE. So there was a series of studies that looked at these collision-based activities to see like how often is this actually happening. So one study looked at football in particular and found that 100,000 to 300,000 concussions are believed to occur in the game of football in an average year. With football players and boxers kind of lumped in there, saying that thousands of subconcussive blows are sustained by each individual athlete through their career. Subconcussive meaning that each of those blows didn't necessarily result in symptoms, but they had a significant head impact. Another study looked at positions, particularly in sports that are increased risk. And this study found that linemen in American football had as many as 1,400 impacts per season. And high school athletes actually have even more than that, roughly around 2,000 impacts per season. And that was attributed to the fact that in a lot of high school athletics, the player is playing both offense and defense. So they're kind of constantly exposed to repetitive impacts. And then another study looking specifically at college football players found that the average number of impacts received by an individual player can vary from around 400 on the low end to almost 2,500 on the high end, with running backs and quarterbacks sustaining the hardest and most severe of the blows, but again, linemen and linebackers sustaining more head impacts. So then how much injury is actually needed? That's the next question. Like, how many times does one have to get hit to get to say that they are at increased risk of developing this down the line? So there's been a few studies on this or looking at this, and one published that they found that published results on postmortem changes in the brain of a patient that sustained one TBI. It was a significant TBI, but they looked at him over the long term, and they found studies postmorbidly that were consistent with CTE when matched with controls. And he didn't have any of the symptoms that were characteristic of the neuro and cognitive and psychiatric changes that precede or make one more likely to have had CTE. So that was an interesting finding. And then they had an animal model study that was published around the same time. And they looked at how many actual episodes of head injury or if you expose an animal model to repeated head injury, what would you find? So what they did is they gave a mouse model, they exposed them to head trauma on 5 consecutive days, and then they found expression of these characteristic findings of CTE, so glial fibrillary acidic protein and phosphorylated tau were found about a month out from the last head trauma exposure that the mouse model had. So that was an interesting finding. And then in terms of age, I mentioned that the younger ages and older ages tend to be more at risk. So younger age, it's believed, when the younger brain is not fully developed, it's exposed to TBI, may begin this series of cascade of destructive events that are compounded through the years of continued play. So assuming they're an athlete and they continue in whatever their athletic endeavor is, repeated concussions ultimately may lead to worsening of learning disabilities or other neurologic and psychiatric problems. The converse argument to this is, well, the younger brain also has more plasticity or ability to heal, and therefore may be able to manage injury better than a more mature brain. So it's a little controversial, but that's kind of what we understand as of right now. Recovery profile and the breadth of consequences in children remains unknown, largely because we haven't followed children. The awareness of this is really kind of now relatively recent, so you have to kind of monitor these children over the duration of their lives. So we don't really know what the full trajectory is going to be as of yet. And then genetic factors. So I mentioned the ApoE gene. So this codes for a protein that's responsible for lipid transport and metabolism. It's implicated in neuronal growth and repair after injury of both the peripheral and central nervous system. And there's 3 main isoforms. So there's the ApoE2, 3, and 4. Now, ApoE4 has been linked to the development of Alzheimer's disease, and that's pretty well established. They found that patients that are homozygous for both, you mean getting both genes of ApoE4 from both of their parents, has been associated with a 19-fold increased risk of developing Alzheimer's disease. Now, this may be a risk factor when you think of it in terms of TBI. This may be a risk factor for the development of Alzheimer's disease in someone that has this and then sustains a significant TBI. It may exacerbate or facilitate the development of Alzheimer's-like symptoms. And an acute TBI was found to induce beta amyloid deposition in about 30% of patients in the study, and a significant proportion of those were heterozygous, meaning had at least one ApoE4 gene um, in that patient. So there's a concern that might be that might be a risk factor for developing this down the line if the patient has this ApoE4 gene. So what's the clinical presentation? So before we talk about the clinical presentation of CT or what's suspected of having CT, we have to distinguish it from acute concussion and post-concussion syndrome. So acute concussion typically manifests shortly after a head injury with a series of symptoms. And they could be a couple of these, could be all of these, could be a combination or kind of a hodgepodge of these types of symptoms. But usually patients complain of things like headaches, blurred vision, amnesia, tinnitus, or ear ringing, fatigue, sleep impairments, dizziness, slurred speech. 80 to 90% of the patients that have this show complete resolution of these symptoms, usually within 10 days of symptom onset. Some patients could take a little bit longer. Usually, almost all are completely resolved by about 3 weeks to a month. When it goes beyond that, so is when someone's kind of labeled as having post-concussion syndrome. So when symptoms of concussion persist for more than 3 weeks, 3 to 4 weeks, that's the general answer for that. And in addition to having those symptoms persist for that long, develop additional symptoms of physical, emotional, cognitive, behavioral problems. Then there's a more variable timeline for when those symptoms typically improve. Most still resolve usually within a year, but in some cases may require several years to achieve full resolution. So chronic traumatic encephalopathy, it's not such a clear linear progression from concussion to post-concussion syndrome to CTE. There's really more of a deterioration over a long period of time that's evidenced by the patient or their loved ones. There's deterioration in attention, concentration, memory, disorientation, confusion, dizziness, and headaches, with progression of symptoms leading to poor judgment and signs of overt dementia. And in severe cases may be accompanied by progressive slowing of muscular movements, gait impairments of more difficulty walking, more shuffle type walking, masked faces, so they have decreased facial expressions, impaired speech, tremors or movement disorders, vertigo, dizziness, and then even deafness can develop in severe cases. So the McKee group, which was one of the two big groups that has been studying this postmortemly, wanted to look at trying to take these cases that they examined postmortem and see, if they can look back retrospectively and kind of determine when these symptoms of CT kind of start to develop or manifest. So they found that the symptoms tended to present later in the lives of these athletes that they looked at, years removed from their competition, from when they were participating in whatever sport they were doing. The average age of onset ranged from 25 on the young end to 76 on the older end. And at retirement, about a third of the athletes they looked at were symptomatic, with another half becoming symptomatic within 4 years. 30% of the subjects had mood disorders. 41% had some kind of movement abnormalities or Parkinsonism, they call it. So it's like Parkinson-like symptoms, but not necessarily Parkinson's disease. Ataxia, which is a poorly coordinated movement. Antalgic gait is a wobbly or off-balance gait. And then dysarthric speech. So their coordination of their muscles to produce speech make their speech less articulate or harder to articulate their words. And then they basically postulated there's this continuous path beginning with this cognitive and emotional decline that eventually leads to motor deteriorations. So based on these findings, the McKee group developed a CT rating scale, which divided the disease into 4 stages. So the first stage being manifested by headaches and issues related to attention and concentration being common. That progresses to second stage, which is shows more mood impairment, depression, explosivity, and then also some short-term memory loss. And then third stage shows progressive cognitive impairments, particularly problems in executive functioning, such as planning, organization, multitasking, and judgment. And then the last stage was basically comparable to full-blown dementia. So the pathophysiology. So largely, the biological mechanism by which this repetitive head trauma leads to CTE is not known. There was a group that proposed a theory that still kind of holds valid right now, or at least is the presumed theory, which is known as immunoexcitotoxicity hypothesis. This postulated that excess glutamate, which is a activating neuro, neurotransmitter, that the stimulation of that and or elevations in pro-inflammatory cytokines are linked to this neuropsychiatric and behavioral manifestations that we see in CTE. What that looks like schematically is this. So you have the normal brain with in its resting state, in like the neurons in homeostasis. The patient gets a concussion. This then puts them into this or gets these microglia, these cells in the brain become primed now or activated. So now the next time they get a subsequent injury, these activated microglia then release pro-inflammatory cytokines, chemokines, excitotoxins such as glutamate and others, and then that results in a cascade in which you get increased free radical production and which ultimately interferes with glutamate clearance and magnifies tau deposition, which we'll talk about in a little bit. But so ultimately, on a physiological level, this is believed to be what's kind of setting off the cascade that results in the manifestations that we see clinically. So then on gross pathology, so all these studies are based on postmortem analysis. So on gross pathology, what you see is these patients tend to have reductions in brain weight. They have enlargement of the lateral and third ventricles and also the cavum septum pellucidum. There's thinning of the corpus callosum, which is what bridges kind of the neurons that bridge the lobes of the brain to interconnect and communicate. Atrophy of the medial temporal lobe, hippocampus, and amygdala is common. Shrinking of the mammillary bodies. These are areas that are very important in memory and cognitive functioning, as well as pallor of the locus coeruleus and substantia nigra, which are areas that are very dopaminergic, have neurons that release dopamine, which is important in coordinating motor activity. So what that looks like here, let's see how to do this here. So this is the enlargement of the ventricle. So you have this ventricular dilatation here. And then in this one, you see the enlargement of the cavum septum pellucidum. It's believed that this can be seen in other neurologic disorders, but it's believed in this case that you actually have atrophy of the brain matter around the ventricles, which makes the ventricle size enlarged. And then in this one, you see medial temporal lobe atrophy. So there's volume loss and like increased concavities in these areas that normally should be a little bit more full. And then this is the substantia nigra. Substantia nigra is the area that has these dopaminergic producing neurons. Should be, as the term says, nigra should be very dark or black pigmented. So as pallor, meaning it's getting more pale, means that the neurons are degenerating. And so you have less dopamine present in this very dopaminergic area. And dopamine, as I said, is responsible for coordinating motor movements. And so loss of that is what's seen commonly in Parkinson's disease and results in a lot of the shuffling disorders and other like motor derangements that you see in that disorder and results in Parkinsonism in patients with CTE. So on a microscopic level, you see neuronal loss, scoliosis, and that's usually characteristically in the frontal and temporal lobes, as well as the hippocampus, amygdala, and substantia nigra. So I mentioned tau protein. So tau protein functions to bind and to stabilize the microtubules that are required for maintaining the neuronal shape and also for transporting cellular cargo, like maintaining the nutritional supply to the cells. Hyperphosphorylation of tau, which commonly occurs after TBI, as well as other central nervous system insults, becomes insoluble. And then it binds to the tubulin, and that moves into the neuronal soma, or the neuron cell body, and it becomes this thing called a neurofibrillary tangle, all bundled up and can't go anywhere, it just stays in the cell. And it kind of basically destroys all nearby structures within the cell. And then eventually killing that cell spreads to other cells. is kind of the underlying mechanism of what the hyperphosphorylated tau does in CTE and other neurodegenerative conditions. Now, in CTE, the tau immunoreactive neurofibrillary tangles are found in the frontal and temporal cortex most commonly. In advanced cases, it can be found in farther reaching areas in the brain, including subcortical white matter. And its appearance is indistinguishable from the neurofibrillary tangles that we see in Alzheimer's disease. Now, how do you distinguish CTE from Alzheimer's disease on a pathologic level? Well, tau deposition in CTE tend to occur in the superficial cortical layers of the brain. So I'll show you what that looks like, but basically the outer layers of the brain, and also at the depths of sulci. So if you were to look at a brain, you see that there's these invaginations, and I'll show this on the next slide. So it tends to be on the superficial level and into those invaginations, and they tend to be clustered around the small blood vessels within the brain as well. In Alzheimer's disease, these tangles tend to appear more in the large projection neurons in the deep layers of the brain. And the perivascular location in CTE is believed to indicate that this is a result of disruptions in the cerebral microvasculature as well as the blood-brain barrier, which may be a result of the trauma itself or repetitive trauma. Secondly, beta amyloid plaques are inconsistently present in CTE, whereas it's a defining characteristic of Alzheimer's disease. And then when it's present in CTE, they tend to be less dense. Like they're very characteristic and dense findings on Alzheimer's disease, and CTE is not necessary for the diagnosis. And when it is present, it's not as dense. The neurofibrillary tangles, or the tau deposition distribution CT, is irregular with foci in the frontal, temporal, and insular cortices, while it's more uniform in Alzheimer's, kind of diffusely spread throughout the brain in Alzheimer's disease. And then finally, the hippocampus, which is a very important component for memory, is often spared in CTE, while in Alzheimer's disease, it's often the first area that's affected. So those are characteristic ways that CTE, while the pathology looks the same, like it's the neurofibrillary tangles, the location is very different. So what that looks like here, let's see. So you see, this is the superficial area of the brain, and these are the sulci, these invaginations. So it's all writing right here on the cortical surface, and the more prominent the depths of sulci. You'll see that here it's these dark areas. It's what's stained on the superficial layers. You go deeper, and you look on a micro level, you see that this is the neurofibrillary tangles at the cortical sulci. So this is that invagination, and this is where it's kind of clustered. And then similarly, this is a perivascular. So this opening is a small blood vessel, and this dark area around it is the neurofibrillary tangles kind of clustered right around that blood vessel. And that's a hallmark finding in CTE. So now, next set of slides, I'm going to talk about some like landmark cases that got published and brought attention to CTE in athletes. So first, there's John Grimsley. He was a former linebacker for the then Houston Oilers and Miami Dolphins. He died at the age of 45 by an accidental gunshot wound in 2008. He had suffered 9 documented concussions. Late in his life, he had been reported to have expressed depression, poor decision-making, and actually had some substance abuse as well. On autopsy, he was found to have, just as I said in the prior slides, this tau deposition in the characteristic locations at the cortical surfaces and at the depths of the sulci. And then this is a micro image of the neurofibrillary tangles on a section for him. And they threw in the publication a control to see like what the same staining would look like on a healthy brain. Next case, Tom McHale. He was an offensive lineman for 9 seasons, mostly for the Buccaneers. He graduated Cornell University. He was actually a successful business person after his NFL career. He had unfortunately developed some chronic pain. He was prescribed opiate analgesics, which reportedly increases lethargy and depression. Ultimately, he began to use having substance abuse with cocaine. He completed multiple drug rehab stints, and he also died at the age of 45, but after a drug overdose in 2008. He had no reported documented concussions in his past. On autopsy, his brain again showed these very characteristic findings of tau deposition at that cortical surface and in the depths of sulci. Get this pointer here. This isn't the amygdala. So this is a kind of another characteristic location to find this clustered neurofibrillary tangles, which are enlarged here on micro. So very characteristic findings again in this guy with no reported documented concussions. Next case is Chris Benoit. He was a professional wrestler for over 20 years. He had a history of multiple concussions in his life. He tragically committed suicide by hanging himself at the age of 40 after killing his wife and children in 2007. Neuropathology slides were studied by the Sports Legacy Institute, which is the group that's led by Bennett Amalu, and they found neurofibrillary tangles in all regions of the brain, including the neocortex, limbic cortex, subcortical ganglia, brainstem ganglia, also with loss of brain cells. Pretty advanced stage type of deterioration is what they found in his autopsy. Then the case of Junior Seau. So Junior Seau was he had a 20-year career in the NFL, most of it with the San Diego Chargers. He had no documented concussions. He was believed to have played through multiple head injuries, though. And after retirement, he did exhibit some personality changes, including attention deficits, memory impairments, depression, and irritability with erratic behavior. He committed suicide via a gunshot wound to the chest in May 2012, and his family donated his brain for autopsy. However, they wanted more of an independent group to do it, so they actually went to the NIH. The NIH neuropathologist diagnosed CTE for him, which was confirmed by an independent review of his brain tissue samples. And the findings included some of those characteristic findings I mentioned in the other cases: clusters of neurofibrillary tangles and glial tangles in the neocortex, primarily at the sulcal depths in that sulci area. He also was shown to have pallor, the left frontal lobe and subcortical white matter. Pigmented neurons in substantia nigra and locus coeruleus were affected. And then the neurofibrillary tangles were also found in multiple other subcortical regions in the brain. They did not release his slides for publication, just kind of the report. So the interesting case of Chris Evans is he was a former wide receiver for the Cincinnati Bengals. He was the first active football player to have been found to have neuropathologic findings of CTE. So Chris Henry died at the age of 26 in 2009 due to a severe TBI that he sustained when he either jumped or fell off of a pickup truck that was being driven by his fiance. He had sustained multiple concussions, both in college and pro careers. He never missed a game, but he had a history of detrimental behavior, multiple suspensions throughout his college and pro career. And on his autopsy, which was done again by the Dr. Amalu group, they found microscopic findings, including tau deposition and neuritic threads, consistent with findings in late Alzheimer's disease. So what was interesting in his case is, this is an active athlete, not a retired athlete, who was seemingly healthy. I mean, he had some behavioral issues that weren't necessarily attributed to chronic head injuries. So it kind of begged the question of when does this develop? So chronic, and that's what stood out. Chronic neuropathic changes found in a young athlete. That's what stood out about his case. And also lent credibility to the theory that the thumping of helmets and the brain inside the skull over time, not necessarily a major impact concussion, can cause these kind of chronic changes, within the brain. And a major concussive blow may not be needed. And the damage can stem from youth sports, because presumably at 26, he was predominantly, most of his career was spent in college and high school sports at that point. And then that begs the question, what age can this start? So the Anne McKee group published an autopsy results on an anonymous 18-year-old gentleman. He was a multi-sport athlete with a history of multiple concussions. And on autopsy, he was found to have focal deposition of tau protein adjacent to these small blood vessels. Again, these open areas are clusters of micro blood vessels with the tau protein deposition all around the kind of hugging around the microvasculature. So this is the earliest evidence of CTE recorded in the youngest athlete, 18 years old, which is a kind of an astonishing finding, because this was someone who hasn't had presumably that much chronic repetitive injury in his life, just because he hasn't lived or had as long of a career as some of these other athletes that they were looking at. So discussion points on this. So first, controversy. So a lot of critics will warn that these cases, while interesting and kind of concerning of diagnosed CTE may reflect more of a biased sample, as they rely on retrospective accounts of the individual's friends and family and are therefore subject to a recall bias. Also, they're a sample of convenience. So these brains that were examined have been donated by a concerned family who suspected that there was a neurocognitive or neuropsychiatric impairment. So therefore, you increase the likelihood of finding some type of neuropathology when you do a postmortem study. Um, they were criticized for having a lack of postmortem controls, like not being able to pair it up to some other, age matched, medical history matched control athlete to see if they had, the same findings and no clinical symptoms. And then some of these cases that I presented to you were only reported through media press releases rather than to scientific peer-reviewed journals. So that was a concern. And then there's this question of whether there's what the impact is of this neuropathologic findings of tau deposition, because the Alzheimer's disease literature has shown that brains of older individuals without having clinical features may show substantial tau deposition. So you can have Alzheimer's, develop these tau depositions, and not show very overt findings of dementia. So the clinical correlation isn't fully established as to how much tau deposition and how much tau deposition is needed to create clinical manifestations, or whether that is directly causing a clinical manifestation. So there was a study that was done in Canadian Football League players, or retired Canadian Football League players. It was a case series of 6 retired players with histories of multiple concussions and neurocognitive decline. Their ages range from 61 to 87, and the duration of neurologic decline ranged from 3 years to 17 years. The study objective was to determine whether retired athletes with a history of multiple concussions will inevitably or invariably have findings with CTE. The results were that half of them did, but they also had comorbid pathologic findings that may have contributed to their clinical picture. And then the other 3 of the cases were found to have other neurodegenerative conditions, Alzheimer's, Parkinson's, and ALS. So the conclusion was that athletes with histories of multiple concussions and progressive neurocognitive decline don't uniformly develop CTE. And other diagnoses of neurodegenerative diseases are also possible in these patients. So the limitations of this study, again, recall bias, the severity of their history of concussions was unknown. The actual number of concussions was unknown. These were older players. They played in a different era when a lot of times, athletes get injured, they go right back out and play. So they were just treated differently. So that needs clarification and to be structured. Aging athletes are susceptible to neurodegenerative diseases, as is the general population. And further research is needed to establish a relationship between these multiple concussions and the development of CTE. And also the prevalence and risk factors that mediate this relationship needs to be kind of elucidated. So how do we diagnose this? It's really difficult to do ante-mortem. As you notice, like everything I've mentioned so far has been post-mortem analysis. There's no available biomarkers currently. There's no consensus on diagnostic criteria or long-term longitudinal correlation between the clinical and the pathologic changes that are seen. And then clinical presentation shares similarities with other neurodegenerative conditions. So kind of teasing that out is also a challenge. We know the history of head injury is insufficient, as head trauma has been cited as a risk factor for other neurodegenerative conditions such as Alzheimer's, Parkinson's, frontotemporal dementia, ALS, and other neurodegenerative diseases. So TBIs are a risk factor for all of those as well. So it's hard to say that that's enough to say, oh, he had a head injury, he had this condition, this must be CTE. So neuropathologic findings are distinct and currently is the only way to really definitively diagnose CTE. There is hope for other diagnostic modalities. There's advances in neuroimaging. For instance, the diffusion tensor imaging, or DTI studies, have shown the ability to show occult white matter changes. So things that, even in a mild TBI may not be seen on like an MRI, a conventional MRI can be seen on a DTI. There is ongoing research to develop and refine biomarker analysis, as well as genetic testing and CSF fluid analysis. So one such study that came out was this FDNP PET study. It looked at 5 retired NFL players with histories of mood and cognitive impairments. They received neuropsychiatric evaluations and got this PET scan. So the investigators that invented the ligand that was used for PET, so that measures tau tangles and amyloid plaque in living brains. It's the only PET probe that's been studied in vivo in human imaging trials. And in previous studies was shown to help differentiate Alzheimer's disease from mild cognitive impairment and normal aging. So it's postulated to be able to predict future cognitive decline in non-demented subjects. So the results that they found was that the FDD-NP signals were actually higher in all subcortical regions and the amygdala, which were areas known to produce tau following trauma. And the results were compared to 5 male controls matched for age, education, and BMI. So while not specific for tauopathies, it did show there was this specificity for regions that typically have tau tangles after trauma. So that, was promising. Players tested varied with regards to the position they played and concussion history. Um, their FTD-NP binding values were greater in players with a higher number of concussions, and their binding patterns were consistent, meaning where they lit up was consistent with fibrillary tau deposit locations found at autopsy in patients with CTE. Limitations, obviously, a small sample size. There was an uncorrected statistical comparison, and then factors that could influence results such as cerebrovascular health and genetic risk were not accounted for. Other issues, TDP43 proteinopathy. So TDP43 is a protein that's expressed in many tissues, including the CNS. It's shown to play a role in mediating response of neuronal cytoskeleton to axonal injury, and it was recently reported to be found in a number of confirmed cases of CTE. So it was previously thought to be a unique finding in ALS and frontotemporal lobar degeneration, but now this kind of leads to the suspicion that maybe this could also be a contributing factor to the development of those things, basically. So like McKee termed the phrase chronic traumatic encephalomyopathy to indicate, so you have CT with these more motor kind of disorders. And this suggests some forms of clinically diagnosed ALS may have actually been associated with the TBI, which begs this question. So did Lou Gehrig have Lou Gehrig's disease? Lou Gehrig's disease is a term that is a colloquial term for ALS. So Lou Gehrig, he played football and baseball for Columbia University. He has 6 known documented concussions. He had this iron horse status, meaning he never took time off for injuries or whatever he played through. And it was diagnosed at a very young age with ALS at 36. Could TBI have been the catalyst for what he ultimately developed? It's an interesting theory that's out there. So treatment prevention. No specific treatments exist, therefore focus is really on prevention, which requires a multifaceted approach. The better educated and prepared all those involved is particularly in youth athletics. So from administrators to coaches to the athlete themselves, their families, referees, team physicians, the more educated they are to screen for and evaluate immediately after a head injury, the better, so that we can better, protect youth athletes. And obviously as diagnostic and other modalities improve, ideally we'll be able to, screen more efficiently for who might be in more risk if they sustain a traumatic brain injury or repetitive head injury. Other areas include protective equipment, so like modifications and updates to helmets, mouth guards have been shown to be effective when worn appropriately. Football helmets today have been refined several times over. They're heavier, they provide more coverage, they're lined with more padding to help absorb shock forces. And the manufacturers are working on newer and newer ways to help mitigate these forces. And then also neck strengthening has been kind of refined and incorporated into more athletes' training regimens. Again, the idea being if your neck musculature is thicker, it supports the head more, they'll be able to absorb the shock of an impact better and not transmit it directly to the brain, or not with as much force directly to the brain. Future research is needed to understand the mechanism of injury and when does the injury cascade begin. Clarify the genetic component. Biomarkers need to be refined to help detect earlier diagnosis and screen, particularly before athletic endeavors are pursued by the patient. Newer imaging modalities aid in diagnosis, and a clear definition of this term CTEM, the chronic traumatic encephalomyopathy. So in conclusion, CT is a neurodegenerative disease. It's believed to be a long-term consequence of single repetitive closed head injury without treatment or a definitive ante-mortem diagnosis. Risk factors include contact sports participation, head trauma, ApoE3 or 4 allele presence, and military service and age. Histologically, it's characterized by tau immunoreactive neurofibrillary tangles. Has an insidious clinical presentation that begins with cognitive and emotional disturbances and can progress to Parkinson-like symptoms. More research is obviously needed to improve our understanding of pathophysiology, antemortem diagnosis, and prevention strategies. And that's it.
Fantastic. Thank you so much. Yeah, that was a great presentation. Thank you again. I'm going to open it up for questions to the audience members. You can just raise your hand and I'll just call on you and you can open your mic and speak. If not, I do have some questions about your talk, which I really enjoyed. So thank you for that. So you talked about some risk factors for CTE, and I was curious. You talked about some cases with some athletes who had suffered from like some concussions that led them to like develop CTE. But like, what about people like who did not like have this history of concussions? Why did they develop CTE? Like, was it more spontaneous? Were they like genetically predisposed to it? Like,
Right. So that's what what's the one of the reasons, one of the things that need to be kind of studied and elucidated more is they found like evidence in neuropathologic studies of patients that have sustained a TBI uh, not from any sports related endeavor that did develop CT as well, or findings on neuropathologic studies of that. So that's part of the studies. And actually, that's one of the things we're doing here at Mount Sinai is with our LET-B study, which is looking at postmortem analysis of people that sustain TBIs, not sports related, and what they end up having on neuropathology. Obviously, that takes time because the patients need to live their life and pass to analyze that. But I think that is coming, and certainly there's a likelihood that there is a genetic predisposition. The ApoE3 and ApoE4 is a leading theory, and then there's others that are being looked at too that might genetically predispose those to sustain a TBI. And then it's also, the other thing that I pointed out was it's a little unclear whether one TBI is needed or multiple. Like that's another controversial kind of debated point, because there's evidence of patients that only had one TBI that developed it, and so it's a lot to still be clarified.
great, yeah, that totally makes sense. And I guess that's the question I do have spilling off of that, like limitation of like diagnosing people with CTE. Like, is there a measure like that you can conclusively diagnose someone with CTE apart from like post-morbid examination?
No, that's the whole point. Right now, there isn't a diagnostic tool for it. That's a hot area of research. That's why the imaging study that I referenced, was an example of that. Like them looking into, if there's newer modalities that could be used to help diagnose in vivo, while in a living person, um, somebody, that has these clinical symptoms, can you diagnose them while they're living? Right now, there isn't any that could be, definitively stated as being diagnostic.
Yeah, that makes sense. That's what I was thinking about the entire time. Like, I feel like the symptoms overlap quite a bit with like other disorders, so it'd be
Yeah.
hard to discriminate between CTE and like other disorders. Great, thank you. And it's like something just like your opinion, I suppose. Just like in the status quo, do you think like the accepted like return to play protocol for athletes is doing anything to prevent CTE in those athletes?
I don't know if it's preventing CTE necessarily, because that again is more longitudinal, like over the lifetime of the athlete. But um, I think the protocols are definitely better in terms of holding an athlete out until they're symptom free, and I think that um, has had benefit in terms of the instance of picking it up and getting these patients educated, their families educated, and forcing the whoever the college, the school, whatever, to hold these athletes out so they're not exposed before their brain is theoretically healed. The long-term implications of having had that TBI, we don't know, right?
Yeah,
That's more longitudinal. But I think in the short term, the return to play protocols have been helpful in giving guidance to schools, at least, which ultimately is what we really care about, is the student athlete, because the majority of student athletes don't actually go on to you know earning millions of dollars in professional sports. They tend to go into something else. So we want to protect them. um so that's kind of the yeah. So in short, I think that it's helping in terms of preventing worsening of the brain, the TBI symptoms from the concussion, and protecting the brain and allowing it to fully heal before allowing the athlete back in.
great. Yeah, thank you. That totally makes sense. Awesome. I don't see anyone raising their hand. If you have any questions, you can like speak out right now, or we can kind of close up. Oh, hi, Dr. Lutman.
Yeah, I actually posted. Hi, Dr. Lercher. I posted a question to you. What do we know about taking a break, taking a sort of a sports holiday from activities in terms of preventing downstream risk of CTE. So if you have an event, usually the recommendation is that you take a break or rest for a while. But what is the evidence that that helps and that you can come back afterwards? Do you know anything about that?
In terms of CTE, there really isn't evidence. That the TBI itself is a predisposed risk factor for the development of CTE down the line. So really, there isn't evidence of that. I think the idea of holding an athlete out until they're symptom-free at rest is more to prevent, symptoms worsening and to help facilitate symptom resolution before they go back. And then, there's the controversial topic of second impact syndrome as well. If you return an athlete to play before they're fully cleared, they're more likely to get injured or sustain more severe injury from a repeat TBI. So I don't think they're directly related, because I think that you hold an athlete out to try to prevent or protect their brain after an initial injury. The long-term implications, that's what remains to kind of be determined.
Thanks.
Yeah, I just got a question from an audience member. We have one last question. So it reads, what do you have to watch out for if you have already sustained a mild TBI or concussion initially in order for it to not lead to CTE, or at least minimize the probability of it leading to CTE?
Yeah, again, I think that's that's what we don't know, unfortunately. I think that's the second part of that question, I think the person wrote is, what's the average healing time for the brain to recover? I think after a mild TBI, patients usually recover a week to, like I said, 3 weeks, a month is the usual time frame that the majority, like 90-something% of patients will have resolution of their symptoms from their TBI. And I think, this is just kind of the assumption based on what we do know in terms of the chronic repetitive injuries. The thought is that will help prevent, further down the line, worsening or deterioration. But, I don't think that there's a direct, like, if I do X, I won't likely get the CT. That's the stuff that we unfortunately don't really know yet, because there's so many other factors at play. We know that the head injury is a risk factor, but there's other things that might be at stake, genetic factors and other things that might be at play to make them more likely to develop it down the line.
Yeah, thank you so much for that answer. It just seems like it's a black box. There's a lot of room for research there. That's both exciting and kind of scary to still not know much right now. But
Yeah.
Thank you for the insightful lecture and talk and answering the questions. I feel like we're just wrapping up to prepare for the next presentation, but thank you again.
Of course, my pleasure. Thank you, everybody.
Yeah. All right, Dr. Lercher.
All right, take care.